Thank you for being here on this Mother's Day weekend. Now, on a more serious note, this is a pivotal time in global health. Among other things, in 2015, we will be transitioning from the Millennium Development Goals, or MDGs, to the Sustainable Development Goals, or SDGs. And therefore, the overarching theme of this conference is the role of universities in that transition. In fact, Universities 2.0, Advancing Global Health in the Post-MDG Era. I will be the first to admit that I'm totally biased, but I think that the many people, some of whom are in this room, who worked on this conference have put together a remarkable 3 days for us. So I'd like to give you a sneak preview of some of what's in store. In terms of that overarching theme, the MDG-SDG transition, there are a multitude of sessions throughout the conference on this. We had originally planned to have 3 plenary sessions on this. 3 days ago, we learned that the first plenary, which was supposed to be this morning and was scheduled to be presented by Jeff Sachs, was not going to be possible because Jeff let us know that due to family illness and his travel schedule, he would not be able to join us. One of the things I particularly love about working in global health and my colleagues in global health is that they're incredibly resilient and there's always a way to work things out. And so in this particular case, I'm very grateful to Tim Brewer and Jim Tielsch, who have stepped into the breach and will be presenting at the plenary this morning. But then tomorrow, Peter Piot will be talking about new challenges for global health in the post-MDG era. And later that day, there will be another plenary panel on this topic that will include Niels Dallaire from the U.S. Department of Health and Human Services, Richard Horton from The Lancet, and Tom Kenyon from the Centers for Disease Control and Prevention. Now, evidence-based programs and policies are absolutely essential to advancing global health. And strong science is critical to providing the evidence for those evidence-based programs and policies. So one of the sub-themes throughout the next 3 days is strengthening the science in global health. And you are going to see presentations interwoven throughout the conference in this area. I particularly want to highlight 8 abstract-driven oral sessions, the abstracts of which are published in Lancet Global Health, and we're very excited about that and very grateful to Lancet for working with us on this. And there are literally hundreds of posters that I hope you will go by and see. In addition, I want to highlight 2 sessions. Later today, please don't miss the session with leaders from CDC. And then on Monday, there's a session with leaders from the National Institutes of Health. It turns out that when you mount evidence-based programs and policies, more often than not, they actually work. And as a result, in part, of the many evidence-based programs and policies that have started to be scaled up and evaluated, along with a number of other factors that are less within our control, we are seeing shifts in burden of disease and therefore an evolution of our global health priorities. And so this is another sub-theme for the conference, and among the many presentations in this area, I want to highlight these that focus on areas such as mental health, chronic diseases, and injury prevention, which are new and very important emerging areas in global health. Clearly, recently there's been a lot in the media, in the press, on environmental and social determinants of health between the work of the Intergovernmental Panel on Climate Change, the IPCC, and the many articles on increases in income inequality and the impact of those factors on health. So this is another of the sub-themes, and among the many sessions that you should look for in this area, I want to highlight session on global health policy, law, and diplomacy today, and then other sessions on global environmental change and social determinants of health through today, tomorrow, and Monday. And finally, of course, CUGH is all about the role of universities in transforming global health. And so the last sub-theme that I want to highlight is the evolution and impact of university global health programs. And here again, there are many, many great sessions, including a plenary later today of university leaders, plenary panel on university leaders in global health. And then later today, among the sessions that I urge you to try to catch, are a session on the many global health consortia that are emerging now in other parts of the world and how they'll start to work together. A very provocative session, including some very interesting new survey data on examining the question of whether U.S. universities can actually manage to sustain our commitments in global health. A session on university non-governmental organization partnerships, and then a session on one of Fogarty's flagship programs, the Medical Education Partnership Initiative, or MEPI, which is quite a remarkable program. In addition, I want to flag the fact that there are 8 workshops on key topics such as global health competencies, enabling systems, student services, and program evaluation. Now, of course, none of this would have been possible without incredible efforts by many, many people, again, including many of you in this room. These efforts were led by the tireless efforts of our chair, our conference chair, Jim Tielsch, who's sitting or standing somewhere here. There he is. Okay, he'll be up here in a minute. And our 2 co-chairs, Michele Berry from Stanford. I should have highlighted that Jim is from George Washington, which is one of our co-host universities. Michele Berry from Stanford, and Keith Martin, our executive director. And Keith has a very special surprise for all of us, which he'll tell us about shortly. And the chairs and co-chairs have worked closely with our executive scientific program committee, which includes Tim Brewer, Jerry Kirsch, Afaf Malis, and Tom Quinn, among others. So with that, I am going to turn this over to Michele to tell you a little bit more about this great conference that we have ahead of us. Thank you all for being here.
Good morning. I want to thank Judy, who's really been an absolute rock star as our executive director on the board of CUGH. She's stepping down this year, and we will miss her completely. To give you a brief overview of the diversity and richness of this meeting, we have, sitting here, or about to sit here because it's early in the morning, greater than 1,400 participants from greater than 50 countries. We're going to have 9 plenaries and keynote sessions, 55 special panels, and greater than 500 posters involving 250 speakers. And some really, I hope, new experimental venues, I like that music. That are debuting at this meeting are the plenary debates, which you'll see on Saturday and Sundays. Now, these should be very provocative. Debates are, as you know, a form of philosophical engagement that dates back to the Greek times, and you'll actually get to vote on who the most persuasive debater is. Our first debate is between Richard Horton and Richard Horton from The Lancet and Nelson Senwankambo from Uganda, and they will be debating whether global health investments benefit countries of the global health north more than the south. And on Sunday, we'll hear from Amanda Glassman from the Center for Global Development and Jisnu Das from the World Bank, arguing or debating whether the next dollar should be in demand or in supply. On Sunday, we also have our first film festival and competition. And these are a variety of films varying from The Right to Heal, about the access to surgery in low-resource settings, No Woman, No Cry, about maternal deaths. We have a series of films from the Pulitzer Center documentary on crisis reporting, and these range from toxic tanneries in India to water shortages in Ghana, ocean acidification in the Pacific, the travesty, really, of child marriage and child brides, and basically other films that the Pulitzer Center has funded. We also have a film by one of our medical students called A Doctor of My Own, which really is a film about the opening of a new medical school in Namibia. And lastly but not least, we ran a competition for video shorts, and we will be showing from students, and we'll be showing them this year as well. I don't want anyone, just a reminder is that please come to the business meeting on Sunday, because there we'll be announcing the student awards for Lancet for the excellence in student posters, the Velge Award for student excellence in leadership, teaching, and projects, and the CUGH Essay Award. And last but really not least, we're giving 2 awards this year. Well, we're giving 1 award, and we're going to hear from 1 award. We're giving the Distinguished Leadership Award in Global Health, and it's our pride to give it to Harvey Feinberg this year. And we're also going to hear from the Canada Gairdner Global Health Award. Satoshi Amura will be speaking to us. So I'm going to now turn it over to my co-host, co-conspirator, James Tielsch from George Washington.
Thank you, Michele. On behalf of George Washington University, welcome to the nation's capital here in Washington. We are delighted to co-host with Stanford this 5th annual conference of the CUGH. It's been our privilege. Michele, do you have the clicker? Leave it to a professor to walk off at the clicker and control it. We are delighted that everybody's here and delighted to host this particularly important event. We have a whole variety of partners, obviously, and partners in terms of sponsorship and just participation in this process, and they range from the University of Washington, AID's Global Health Fellows Program, NYU, the Cancer Institute, and the NCIAA in this process. And of course, supporters across the board, key ones including a variety of other universities, the CSIS Lancet, of course, and a variety of others, including translational medicine from AAAS. These kinds of meetings, obviously, pay a lot of tribute to a couple of people or a few people at the very top of the thing at the pyramid, but obviously those people don't do most of the work. The vast majority of the work is actually done by the members on the Scientific Program Advisory Committee. You can see them listed here. They spent enormous numbers of hours, time, energy, and attention to commitment to choosing and helping select the topics that you're going to hear over the next 3 days. So a great shout out to everybody that participated in that process, and a great degree of appreciation. We also have a Trainee Advisory Committee, as this is a consortium of universities of global health. Trainees are an integral part of what we do and how we do things, and we appreciate their contributions as well. And or more important than anybody else, is a conference management team, really led by both Keith Martin as the executive director of CUGH, but Karen Lamb and her colleagues, Shanika Thurman, Catherine Unger, Jillian Morgan, Dahal Najjar, and Doris Steinbach for actually helping us get this entire thing put together. So many, many thanks, and we look forward to a really exciting and important conference. I am now going to turn this over to Dr. Keith Martin. For those of you who don't know him, he is a Canadian physician who came about 2 years ago to CUGH, as executive director. He knows a bit about policy and politics as a former Canadian parliamentarian himself, and I think is uniquely positioned to kind of build the base and collaborative relationships of CUGH with a variety of other global health partners here in DC and elsewhere. So Keith, it's up to you.
Thank you very much, Jim. Good morning, everybody. Good morning. Fantastic. This, as you heard earlier from Jim, Michele, and Judy, this is an absolutely awesome conference that we have for you. We look forward to enjoying every moment that you're here, particularly the reception that we'll have tonight. So be there. And part of the reason that we're here today is to meet each other. So one of the things we've done is we put a conference app. So please go down to the App Store, download it, and you'll get all the information, the up-to-date information about our conference on there. As Jim mentioned, this would not have happened without the remarkable efforts of a team, and Jim mentioned the individuals involved from Karen and Catherine and Jillian and Shanika, but none of this would have happened without the extraordinary help of one individual. In fact, we wouldn't be here without her, and that is our conference manager, Karen Lamb. So I'm going to embarrass Karen, so please put your hands together for Karen Lamb, please. She hates that, but she deserves it. Ladies and gentlemen, there's a couple of housekeeping notes I just want to talk about for a second. One is you need to fill out your CME forms if they're relevant to you. Please do that. There's also an evaluation form attached to that. They'll be either on the conference app, which is the easiest thing to do, or you can get the paper form downstairs at the registration desk where you signed in. The abstracts you've seen, please go and see the poster awards. One group will be up today, another group will be up tomorrow. You'll be able to, in fact, see all of the poster abstracts online, and much thanks goes to Richard Horton and Zoe Mullen. They've been fantastic with us and are sponsoring the awards tomorrow. They're also the oral poster awards are in the booklet that you have there. I also would like to thank the individuals involved from the National Cancer Institute, the National Center for the Advancement of Translational Sciences, the Public Health Institute, and USAID. There were 3 incredible satellite sessions yesterday, and I hope for those of you who attended, you enjoyed it. For those of you who will come to our next conference in Boston, please go to those sessions that we hope to have. They're a great way to bore down into some of the big challenges that all of you face. Lastly, I just wanted to as was mentioned earlier, we have a little surprise. The work you do is something of vital importance to the world. And one of the reasons for moving the Secretariat here to Washington was that the board decided 2 years ago, was for us to be able to do a better job of being able to advance global health, being able to engage different parties, particularly here in Washington, to showcase the work you're doing and to give you a chance to be able to engage more effectively with the power structures here and around the world. One individual who has spent his entire life trying to do this, and who, as you'll see, is a big supporter of ours and someone who understands what you're doing to be able to relieve suffering and improve the lives of those least privileged in our world, has sent us a short little message. So please sit back, enjoy this. Mike, if you roll the video, please.
Hello, everybody, and welcome to Washington. And thank you to the Consortium of Universities for Global Health for bringing you all together today. In the Universal Declaration of Human Rights, our nations recognized the inherent dignity of every individual, including a right to health for families and children. And over the decades, we've worked together to save millions of lives, from eradicating smallpox to increasing access to clean water, to vastly reducing the tragedy of childhood deaths. As President, I've made it clear that the United States is committed to being the global leader in health and development, in partnership with all of you. We changed the way we approach development with a new focus on building partnerships that empower countries to break the cycle of poverty and dependence. And together, we're making progress. We're investing in research and vaccinations to help children and mothers live longer, healthier lives. We're providing life-saving therapies and strengthening prevention efforts to bring us closer to the first AIDS-free generation. We're improving our ability to respond to outbreaks of infectious disease before they become pandemics. Our food security and nutrition efforts aim to lift 50 million Africans out of poverty. We're building the capacity of countries to care for the health of their own people and working together to end the injustice of extreme poverty. Our goals may be ambitious, but they're achievable, and realizing them will take the passion and dedication of global health experts and development workers, including all of you. Like you, I believe that no one should die from an outbreak that could have been stopped. No child should suffer from a preventable disease. No mother should fear giving birth. That's our shared vision. That's what we're working for. So thank you for the hope you represent. Thank you for the life-saving difference you make around the world every day. As you go forward, know that you will always have a partner in me and in the United States of America.
And on behalf, I think, of all of us, I'd like to thank President Obama for taking the time to do that, and also our friends at the State Department for making that happen. And I think, ladies and gentlemen, that is a shout out and an acknowledgement of all the work you do tirelessly, yourselves and with your partners all over the world, to tackle some of the most compelling challenges that face us. So, as was mentioned earlier, unfortunately, Dr. Sachs was unable to be here, but we have a 2-for-1 deal. Indeed we do. We try to create value at CUGH, as you know. So we have 2 incredible speakers here today. The first is Dr. Tim Brewer. Dr. Brewer is Vice Provost for Interdisciplinary and Cross-Campus Affairs at UCLA. He was the Director of Global Health Programs at McGill University in Montreal. He's an ID specialist who's worked for the CDC, the WHO, and the National Institutes for Health. He is CUGH's Vice Chair, but for his sins, he's taking on the role of CUGH Chair. So if there are any big questions or problems, please go and ask Tim. And also, I have to say that he has absolutely the coolest vacations ever. I live vicariously through him. He's swimming with whales and places you can't imagine. So talk to him about that too. So it's a real privilege today to introduce Dr. Tim Brewer.
So I get the pleasure of not being Jeff Sachs, following the President of the United States, and doing this all on 3 days' notice when I spend one day flying across the country and the next day in meetings, and they have somebody else's slides up. So could we get my talk? Excellent. There we go. And if we could put it up on the screen. So what we're going to talk about today is building a global health curriculum, because at least in the health sciences, I think we're getting to a point where we're transitioning from global health as a specialized knowledge to something that might be core. I'm curious, how many of you, just a show of hands, are from the non-health sciences, law, engineering, undergraduates? Okay, we got a couple. All right, from the health sciences? Woo, all right. So, thank God I actually know something about that. So, here we go. If I can figure out how to make this work. I'm pushing the green button. There we go. Okay, so we're going to start with what is core knowledge for a well-rounded education. I put up here undergraduate, health science, legal, engineering. We're really going to focus primarily on health sciences, but I'll give you two examples from universities that I've been affiliated with. So if you went to Harvard Law School, you had to take property law in your first year, and as part of taking property law, you learned what the difference was between a first cousin once removed and a second cousin. Because Harvard Law School decided that that was core to being a lawyer. You couldn't be a lawyer without understanding that fact. And then if you came up north to McGill Medical School, where I was for 7 years, we decided that whether you were a gastroenterologist in Toronto or a family practitioner in Abitibi, you had to learn the structure of collagen. And so I'm just curious, of those of you who are in health sciences, how many of you learned the structure of collagen? Excellent. So you also went to premier medical schools. Now, if you were at Harvard, you did not have to learn about the Universal Declaration of Human Rights. And this is Eleanor Roosevelt, and she's showing it off. She's one of the drafters. Now, for all I know, you could have learned it. I actually didn't go to Harvard Law School, but I did ask my colleagues who did and were on the faculty there. And so you could have taken a course potentially and learned about that, but Harvard did not think knowing anything about the Universal Declaration of Human Rights was core to being a lawyer. And up at McGill, we actually had an elective course on the global burden of disease, and one of the things you could have learned about in that course is over the next 15 years, the prevalence of diabetes around the world will roughly double, that there'll be about 330 million people with diabetes, vast majority of them in 3 countries, United States, Indonesia, and India. India will have more diabetics than anybody else. The highest prevalence would be in the Middle East. About 9% of the adult population in the Middle East will have diabetes. But again, you didn't have to learn that. That was not core to being a physician, at least where I was. And I'm just curious, how many of you learned anything at all about grizzly bears or Big Macs? Oh yeah, okay, we got one. So I'm just, Peg, was it a grizzly bear or a Big Mac? It's a Big Mac, excellent, okay. So I'm gonna hopefully convince you that if you go to a top-notch health science program, they're gonna teach you about grizzly bears and Big Macs. All right, so hold that thought, we're gonna come back to that. So what we're gonna do is we're gonna talk about moving from boutique to basic. Basically, how does a body of knowledge become core to what we do as professionals? And we're going to run through thinking about competencies. We're going to understand where we started out. We'll talk a little bit about building consensus, a little bit about who we're trying to teach, and then hopefully I convince you at the end that global health is something that everybody in the health sciences needs to know a little something about. So I'm actually not going to give you a definition of global health. You've all read them. They've been in the Lancet. We've had a couple of different ones. And, you know, this is a meeting of global health. You probably know what it's about. To me, it's health issues that transcend national borders, and it's partnerships. That's all it is. You know, those two things. If you got partnerships, you're doing this with somebody else, you have to solve the problem together, and it's a problem that affects both of you in health, then you're doing global health. But you may not spend a lot of time thinking about competencies. And so I have a definition here of competencies. And the critical thing with the definition on competencies, if we can get the pointer to work, is down here on professional Oops, not, it's sort of, here we go, professional performance. So a competency actually involves an action. And that's important because an action is usually context specific. What do I mean by that? So if you're a competent physician at the Children's Hospital in Los Angeles, California, that doesn't necessarily mean, even though you have a very good set of knowledge, skills, and hopefully attitudes, that you're a competent physician in Lagos. And so part of understanding competencies is recognizing that they include both actions and they can be contextually specific. And so that's part of why we're starting to think about competencies now instead of just knowledge, skills, and attitudes. So when you get to global health is a little different than most of the things we learn about in the health sciences. So regardless of where you went to medical school or nursing school or PA school, physician assistant school, we all tend to pretty much agree on where the liver is and what it does, right? So there's nobody saying the liver's over here somewhere and it's filtering urine. And yet when you get to global health, that's not the case at all. And so with a group of students, we actually tried to figure out what do people understand about global health. And so one of the ways you do that is you do a literature review. So we did that, and of course that means you only look at things that you can find electronically, and you only do it in languages that you can actually read. But if you accept those caveats, we think we did a pretty good job. And what we found is that there was really no consensus on what people were writing about in the health science literature about global health. And not only was there no consensus, there in fact was very little information on what you should actually teach people if you wanted to teach them about global health. And in fact, at least when we were doing this, there were very few definitions. And so while there was some concordance around recommended topics, so travel medicine seemed to pop up a lot, there was clearly a lot of work that needed to be done. The other thing you can do is you can do primary data collection. So I'm an epidemiologist. I think that's a useful thing to do. So this again was actually done by McGill medical students. And so never underestimate the power of medical students and other trainees to acquire knowledge and get things done. So all of the work that I'm showing you from these last two slides was all done by medical students. And so we did the first national survey of global health programs as far as we know it ever been done. And basically what we found is it was all over the map, okay? And so there was a greater than 10-fold difference in the amount of time spent on global health. There was no consistency in the topics that were taught. There was no consistency even in what people were talking about in terms of global health and whether it was mandatory or elective. So one of the first things you have to do is you have to figure out how do you build a consensus. And so this was the approach taken by the Association of Schools of Public Health, and Pierre Buchans, who happens to sit right here in the first row, was the chair of this really momentous effort. And so what they did is they got together a bunch of experts from schools of public health, and they tried to figure out from the perspective of schools of public health for individuals who are taking masters, exactly what does it mean to be competent in global health. And so you get these experts together, you sit in a room, you talk until you're all tired of each other, and then you come up with a list of competencies. And then what you do is then you turn around and then you give that to more experts, and you say, this is what we think, what do you think? And of course, because you're bringing in new people, they say, no, you've got it completely wrong, because otherwise they feel like you've wasted their time in bringing them in. And so then they do it all over again, and you come up with a new list of competencies. And because the Association of Schools of Public Health is way more thorough than I would be, they did this a third time. And so they brought in more experts, more discussion, feed it all back to their original experts, and at the end of it, they come out with their set of models for what they believe are the core competencies for global health if you're a master's student in public health. Well, this work has actually been done across the health sciences. So there was a group from the Associations of Faculties of Medicine of Canada and the Global Health Education Consortium that tried to do this for introductory medical students. There was a group led by Linda Wilson who tried to do this for nursing students, and I believe they had PAHO programs involved as well across the Americas. And of course, as I mentioned, the very stellar work that Pierre and his colleagues did with master's students in public health. So the question is, okay, now that you've done that, where do you go from here? And so the first question is, well, is there anything that's common across all of these competencies in the health sciences? And I'm not going to dwell a lot on that today, but if you're interested in this topic, and I think it's a very interesting and important topic, there's actually a workshop today in the Columbia 3-4 room chaired by Linda Wilson and her colleagues that have been working on this. And you can see sort of the range of disciplines that they've been scanning to really understand, okay, what are the competencies in global health, and how can we push those all together? So I'll give you one quick example on the, I guess, I would say left and right, but I realize you and I have the different left and right. So this side here is the schools, the Association of Schools of Public Health, and this side here, if my mouse will move, is, well, the other side that says global burden of disease there, okay? So that side is what the Associations of Faculties of Medicine in Canada and CUGH came up with for medical students. And you can start to see that there is some potential overlap there. And I want you also to just keep in mind ethical reasoning and professional practice. We're gonna come back to that as we get a little further along. And so you can start to drill down into this a little bit. So if you're a practitioner of public health, what does it mean to be competent in the right to health? So what you're really talking about is engaging marginalized and vulnerable populations in health decision making, okay? And if you're a physician, what that group thought was really important was really understanding that, yes, individuals and communities have right to health. That is a fundamental right, and in fact, there are social, economic, and political conditions that can impact on that right. So what else do we need to be thinking about? So you remember I mentioned, just keep in mind ethical and professional practices. So there's a group up at the University of Maryland in Baltimore led by Judy Olson and Virginia Rowthorne, and they're reminding us that actually there's been this field called interprofessional competency since the 1990s, and that really came into being to understand how we get doctors and nurses and physician assistants and nurse practitioners and everybody else in the health field to be able to work together. And they asked the very interesting question, what is it that we know about interprofessional competencies that may be relevant to global health? And so what you see here are some of the interprofessional competencies that were developed by an interprofessional collaborative in Washington in 2011. And you can understand that there's definitely likely to be some overlap, values and ethics, how we talk to each other, how we work in teams between some of the competencies that the Association of Schools of Public Health have developed, medical schools, nurses, and others. And so we're starting to see this convergence, this consensus, if you will, as to what might be the field of global health. So what else do we need to think about? We need to think about who we're actually trying to train. And again, this is some work that Linda, Brian Callender, and others are doing, where what they're trying to think about is, okay, who's my target audience and what level of knowledge is appropriate? So by global citizen, what they're really talking about is undergraduate education. So these are individuals who are probably not going to go into a career related to global health, but are interested in being good global citizens. And as you progress on forward, you get all the way down there to advanced, So that's probably most of the people in this room, individuals for whom global health is likely to be a significant portion of what they do, and you're likely to have a sustained involvement over your career. And again, I think the workshop today at 1:30 will touch on some of these issues if you're interested in more. Finally, you have to figure out how to teach it. And so at least when we looked at the literature, these were the most common approaches. You get people lecturing at you like I am, and that's, to be honest, actually the worst way to teach. There are great data to show that you're probably spending your time on your cell phone and doing other things, and I appreciate that. That's okay. Experiential learning is a little bit better. Peer education tends to be good, and actually being involved in research and scholarly activities. So the final thing before we get back to grizzly bears and Big Macs is understanding the differentiation between what is really core and what is specialty knowledge. How many of you learned about ameloblast? Anybody know what an ameloblast is? Excellent. So you are actually very happy that you have ameloblast, because ameloblasts make tooth enamel. And it turns out that if you don't have teeth, and we have colleagues at UCLA or have this wonderful project in Latin America on children's oral health, that it creates all kinds of problems in terms of malnutrition and development and developmental delays. It affects your mental health and your outcomes. And so every morning, thank your teeth and your ameloblasts. But the question becomes, as a physician or a nurse or a health practitioner, do you really need to know that ameloblasts are on the job? And so is that really core knowledge? Whoops, I went too fast. I tried to do the pointer there. And at least at McGill Medical School, the answer was yes. You were going to spend 2 days immersed in ameloblasts. And you were not going to spend any time at all learning about the global distribution of emerging diseases. So what you see on the other side there, that map there, is an article that was published in Nature in 2008 with 40-year review of emerging disease outbreaks, breaking it out by vectors, antibiotic resistance, a variety of different ways. But that wasn't, at least in 2010, not considered core knowledge at McGill Medical School. And so as you're developing your curricula in global health, that's a challenge that each one of you is going to have to grapple with. It's really trying to understand what is core and what is specialty. All right, as promised, we're back to Bears and Big Macs. This is what we've all been waiting for. So you heard, I found out that I was giving this talk on Wednesday night. I spent all of Thursday on an airplane and all of Friday in a meeting. So what did I do on that airplane? I probably did exactly the same thing you would have done. I read the in-flight magazine. And I flying from Los Angeles to National, and the only way to fly from Los Angeles to National is Alaska Airlines. And they call it Delta or American, they disguise it, but it's actually, once you get on the plane, it's Alaska Airlines. And so the in-flight magazine is talking about salmon runs, because this is the month of May, and in the Copper River up there in Alaska, in the month of May, this is when the salmon start to come back, okay? And this is apparently a really big deal in the Pacific Northwest, right? So if you're from Seattle, you're probably not going to eat anything but salmon for the next 4 months, right? Because they're all coming back. But we do global health, and part of global health is One Health, and so we think about other species too. And so I kind of asked the question, even though the Alaska magazine did not, what other species are interested in salmon? And of course the answer was grizzly bears. And it seemed to me that salmon runs were the McDonald's of the grizzly bear world. So what do I mean by that? Here you go, you got this very nice, healthy-looking grizzly bear, and he's gone to the salmon run counter, and he sees this 2 all-beef patties, special sauce, lettuce, cheese, pickles, onion on a sesame seed bun swimming by. And he says, I think I'll have one of those. Boom. And he picks it off, right? And you know what? Grizzly bears probably don't have any control when it comes to salmon. So he says, I think I'll have another one. Boom. And before you know it, this grizzly bear starts putting on weight. And before too long, this grizzly bear becomes obese. And all the health consequences of that. Because if you think about a Big Mac has 550 calories in it. So that's roughly 1/5 of the calories you need every day. If you're a 20 to 25-year-old guy, it's about 1/4 of the caloric intake you need if you're a 20 to 25-year-old woman. And if you're someone like me, it's somewhere between 1/4 and 1/3 of your entire caloric intake for a day. So think about the last time you successfully stalked and captured a Big Mac, right? You probably did not expend 1/3 to 1/4 of your entire energy needs for the day getting that, right? So the question then becomes, do we have any more control than grizzly bears, right? So here we are, we're in the United States, it's 1985, there are about 320 million of us. We're just kind of milling around, minding our own business, and all of a sudden, a bunch of Big Macs start swimming by. And so what happens? So we put on weight, and some of us get obese, okay? And so lest you think that, I know what you're thinking, Tim, that's not really all due to Big Macs swimming by. So I actually just had a very interesting thought, which is I would actually probably go to McDonald's more if they threw the Big Macs and we had to catch them in the air with our teeth. You know, I suspect we do not have the same eye-mouth coordination that a grizzly bear does, but it would make it a hell of a lot more interesting. And so you say, well, that's not really what's going on, but then here is a map from the World Health Organization of the global distribution of obesity, and as you can see, unfortunately, the United States, we're kind of leading the charge. We're up here over 30%. The Canadians aren't quite as bad. You can see South Africa is pushing, and the Middle East not so doing well. These little tiny dots are places like Tonga, which is where you can actually go swim with humpback whales, and I've done that. But you know, in Tonga, it's about 67% of the adult population is obese, and here is the global distribution of Big Macs. And so you can see the United States, we're not doing so well. We got lots of, that giant Big Mac here is the number of McDonald's in the United States, so we got lots of them up here. We got them down in South Africa, we're up in the Middle East, we're out here in Australia, and Japan is kind of the one outlier. They don't have a lot of obesity, but they do have a lot of McDonald's. And while I didn't have time on the plane because I had no biostatisticians with me. I didn't realize I should have packed a biostatistician. So I couldn't actually do a regression of the primary data for these. I would suspect that these are highly correlated. But we are good enough epidemiologists, you and I, to know that correlation is not causation. But I would posit to you that understanding how food travels around the world, how corporate and individual rights affect health, how disease and disease risk factors are changing around the world are as important to a modern professional health science education today as the structure of collagen. Thank you very much.
I don't know about you, but I don't know when the last time I heard anybody connect Big Macs, grizzly bears to NCDs. That's the magic of Tim. Maybe if you swim with whales in and around Tonga, that's what you can do. Who here is on Twitter? Okay, fantastic. Well, that you're on Twitter, we want you to be able to tweet the living daylights out of this conference. Please use hashtag CUGH 2014 and use it wherever you are in the next few days. We'd really appreciate that. One of the things we try to do in our office with Karen and Dalal, who's our Director of Operations, Jillian and Catherine is sitting right there. Raise your hand, Catherine. Catherine just had a big birthday yesterday. So happy birthday, Catherine. We created a new website, and it's cugh.org. We hope that you will use it. It's an entirely new platform, and it's designed for you to be able to share knowledge, share best practices, build collaborations, and have impact. And there's some amazing forums on that site across an array of 15 different global health challenges. So please check it out, and please use it, because it's only going to be as good as it's used, and it's a chance for us to really have a huge impact. When you walk into a chair's office of a department, you fully expect to have an amazing electric guitar on the wall, right? Signed by an award-winning musician. Well, when I went into Dr. James Tielsch's office at GW, when he first started there not so long ago, that was what was sitting in the corner. I knew he had to be a very cool person. So James has been kind enough, not only is he the chair and stepped into the breach to be the chair of this conference and has done a fantastic job, but he is also the chair of the Department of Global Health at George Washington University, an epidemiologist who's done an array of amazing things, from dealing with blindness, diseases affecting blindness, to malnutrition, to maternal health. He is truly a man for all seasons when it comes to global health. And just when you want to find out where he is, if he's not in town, where would you expect him? Nepal, of course, where he does some incredible research. So we're really happy that James was good enough to be our chair. We were privileged to have him, and we're doubly thankful that he's also chosen to come in and give us the second keynote for today. James, thanks very much.
So Tim complained that he had to follow Keith and President Obama, and I'm going to complain that I have to follow Tim, because I have no chance of talking about grizzly bears, salmon, and Big Macs and making that all connection. So Tim decided to spend his time talking about the education process, and I thought I'd talk a little bit about research in the post-MDG, post-transition era, just because I think there's a wide variety of interesting opportunities, and this in no way can cover the entire spectrum of research opportunities and or agendas that might apply in global health, especially in this post-MDG, post-transition era. So think of this as Tielsch's sets of interesting topics that I wish I could spend my time and energy on over the course of the next decade or so. The MDGs were an important factor in mobilizing a whole variety of both programs, but also research to feed those programs. And I think it's important to remember and to talk to our programmatic colleagues about the fact that today's programs were yesterday's research, and tomorrow's programs will be based on today's research. So continued investments in research is an important part of what we need to be doing, and especially universities. So MDG progress has been incredibly impressive. Next year is the official end of the deadline for the MDGs, and I'd like to just go through a few of the goals that were originally set by the MDGs and talk about where we are with those. And I'm not going to present a lot of data on this, but to talk a little bit about what that means for the next steps. The poverty goal, if you'll remember, the idea was to eliminate or to, reduce extreme poverty by 50% in the world's population. In fact, that goal, surprisingly, has been met, but 1.2 billion people still live in extreme poverty. So that's how bad the situation was, 25 years ago, and it's much better now, but we still have a very, very long way to go. The primary education goal was universal primary education and enrollment, and I'm not sure that's ever possible to meet, but we're getting pretty close, and there has been huge progress and much better gender equity in terms of enrollment and participation in primary education. The gender equity goal also not met, and lots of work to be done. There were a whole bunch of separate markers of accomplishment in that arena. Some of them were tremendous progress has been made, and others where very little progress is made. So there's still a huge unfinished agenda there. The child survival goal was not met and is unlikely to be met, although in some places in the world, and I work a lot in Nepal, one of the poorest places in the world, Nepal met its MDG 4 goal 3 years ago. So it is possible to do it without tons of resources, and so long as you have a strict and educated focus on what actually makes a difference and an ability to commit to a community-based strategy. The maternal health goal as well is not met, but there has been dramatic progress on maternal mortality, which is the key indicator there, and shocking progress, much beyond what many of us had anticipated for maternal health, but we're not there to the end. The HIV, malaria, TB goals really have been met, but they were met because they were so unquantitatively defined in the MDG goals to begin with, and that the goal was really to make progress in making some progress, and we certainly have made significant progress, but obviously challenges remain. The clean water access goal, which actually was a subset goal of the environmental sustainability goal, actually has been met, but many other parts of that environmental sustainability goal still need to be met. And the global partnership goal, again, one of those kind of ones that's hard to get your quantitative hands around. I'm an epidemiologist, so I like numbers. Is still a work in progress. And so there's a large transition of activities that I think needs to continue. The SDGs, exactly what's going to happen with the SDGs is not completely clear yet. There are probably 20 or 30 different documents proclaiming what the SDGs actually will be. I think we'll hear more about that later this year. So the exact goals have not been finalized, but suffice it to say they are going to be much broader and more inclusive than the Millennium Development Goals were, and they're going to include a broader and a more sustained focus on economic development and environmental sustainability and social inclusion. Within each one of those goals, if those are the big themes of the SDGs and they survive, clearly health plays a very important role in each one of those, and we can certainly think of markers in the health sector that can help us decide whether or not those goals are being met. So stay tuned for SDGs. I do miss the fact that Jeff Sachs is not here to talk specifically about this because he's been very heavily involved, obviously, in the SDG agenda. I'd like to talk a little bit now about research and issues related to the post-MDG and really more the post-transition agenda, because I think we're in the midst of a whole variety of large-scale trends. The demographic, epidemiologic, and nutrition transitions are well underway everywhere in the world, and we still have a wide variety of things to do. Clearly, the MDG, the original MDG agenda is unfinished. And we have a huge unfinished agenda in that arena, and we can't take our eyes off the ball in terms of either programs or on the translation of research into policy and action, right? Some say, and I hear this all the time from my programmatic colleagues around the world, that it's time we know enough, and I've been hearing this for 25 years now, we know enough and it's time just to implement. We really need to spend our time, energy, money on implementation of programs and really need to divert some resources out of research and into those programs. Unfortunately, you hear that a lot. It ignores, of course, what we don't know about translation and scaling. Those are two entire research agendas in and of themselves, many of which the audience here works in quite actively, but there's a whole science agenda related to translation and scaling up. It ignores the potential for new, more cost-effective interventions that might come about because of research, and really, I think, is a harmful perspective in terms of what's going to happen in the future. The other thing the MDGs didn't account for is these transitions, these demographic, epidemiologic, and nutritional transitions that are happening pretty much everywhere in the world. So they didn't account for those. They didn't talk about them very much. And so that is certainly part of our post-MDG agenda. So I'm just going to go through a few of the areas for the future, for the post-transition agenda that I think are going to be important, that are a mix of unfinished agenda and new items that I think are critical issues for further research and development and translation to policy and programs, and once we understand them a little bit better. The first one, and I always like to start at the beginning of life, and that is pregnancy outcomes. And that includes issues like unsafe abortion, stillbirth, preterm birth, small for gestational age, and complications of labor and delivery. You know, the numbers of these particular events are truly massive, and much of the underlying causes of these particular disorders we don't understand well still to this day, and our current interventions, in fact, are only modestly effective. It is true that if a woman delivers in a very safe, clean environment in a strong referral hospital where she's got the ability to be referred for care in case an emergency occurs, that many of these things won't occur. But of course, the vast majority of the world's population, the world's women, don't deliver in those kinds of settings. So stillbirths about 3 million a year, preterm births 15 million a year, SGA babies 30+ million SGA babies a year, and that's just in low and middle income countries. And then obviously a whole set of issues related to complications of labor and delivery. I think this is a huge unfinished research agenda and offers the opportunity for immediate and instant, practically, translation to programs and policies if they can be accomplished, if we can learn a little bit more about this. Child health, part of the MDGs, a core part of the MDG, probably the one besides maternal health that most of us in this room work on and have been talking about and thinking about for the last 15 or 20 years. There's a huge unfinished agenda. We now have less than 7 million under 5 deaths in the world per year, a huge accomplishment, and many places, like I said, many countries have actually already met their MDG goals. But neonatal deaths are growing in terms of their action and their importance. And as under 5 mortality comes down, the proportion that's explained by neonatal deaths goes up. It's now somewhere in the range of 40% of all under 5 deaths occur in the neonatal period. And we desperately need new approaches to a whole variety of the major factors that cause neonatal deaths. And that includes infection control and or management of neonatal sepsis, what those algorithms are like and how they work. Management of birth asphyxia, we have some new and interesting opportunities there, but there's still a long way to go. Certainly doesn't take care of all the birth asphyxic events. Nutritional support issues, and then, of course, the impact of newborn care practices or packages on this process, and the translation of how you make those packages cost-effective, how you get them implemented, how you translate them into actual action and showing up at households to make a difference is an important research agenda, a translation agenda that needs to be solved. Child growth. Child growth remains the big bugaboo among those of us who are interested in child nutrition. Despite 30+ years of research in trying to prevent stunting and other forms of malnutrition in kids, we still have huge proportions of the population, especially in low and middle income countries, that fall off the growth standards sometime at around 2 to 3 months of age and continue to fall off until 6 months, until they're weaned. Stunting, there are 195 million stunted under 5 children in the world, 195 million. And despite 30+ years of community-based nutrition intervention, aggressive nutrition intervention trials that have been done around the world, there is not a single trial that has been done where in the intervention group we have been able to normalize the average growth of that population. Not one. So we have routinely failed to make a difference in terms of the stunting outcomes. And stunting, as you well know, is associated with long-term mortality risk and a whole variety of other adverse outcomes in terms of child development and then subsequent chronic disease later in life. So a huge unfinished agenda where research is critical to understanding what exactly we can do about this. I am not an HIV expert, a malaria expert, or a TB expert. I've done a fair amount of work on NTDs, but clearly the research agenda for these particular topics is grossly unfinished. While we have great news in terms of treatment efficacy for HIV, prevention of malaria with aggressive bed net distribution and a combined strategy for treatment and identification. And certainly on the NTD sides, aggressive programs for both lymphatic filariasis, onchocerciasis, trachoma, and a variety of the other intestinal helminths. Clearly, we've got a long way to go in terms of sustainable and cost-effective solutions in those environments, including the whole area of vaccines. New drugs and new combination drugs certainly are going to be needed, especially in HIV as we go forward, as drugs become less and less effective as they're used more. And a specific focus on primary prevention activities is going to be critical here to maintain costs and improve outcomes. And then the whole integration with other healthcare services, and you're going to hear a lot of talk, and there's a whole session later this week on the integration of HIV with NCD management and whether or not that is a good idea. I will leave my own personal opinion aside on that and invite you all to comment on that at that particular session later this weekend. Obviously, there are huge challenges in the post-transition agenda. The increasing prevalence of risk factors for NCDs, driving the increased incidence of non-communicable disease. By the way, I really hate the term non-communicable disease. I don't know why WHO selected that. I've never met a disease that wasn't communicable in some way, shape, or form. Whether if you believe in social determinants of health and environmental determinants of health, I don't see how you can possibly not believe in transmission or contagion of risk factors. I think Tim pointed out a great example of that with his spread of Big Macs around the world. But I will continue to use it because that seems to be the current standard. But globalization is a key issue, and one that Tim referred to as well, resulting in the transmission of these risk factors. And these are some data that have just come out in the World NCD Status Report from WHO in 2011, and just shows that, premature deaths, the vast majority of premature deaths due to chronic diseases are occurring in low and middle income countries, right? We obviously are accustomed to chronic diseases here in the United States and in other parts of the industrialized world, but clearly the premature deaths that are occurring are happening primarily in those countries with limited resources in order to deal with them. And they're happening at relatively younger ages as well. If you look across the board about why we should care about this, certainly not only is health a human right and the compassion that we have for people who have these kinds of conditions, but money is a big deal here. And the amounts of money that can be spent and projected for the management and care of these kind of chronic diseases around the world is truly staggering over the next 15 to 20 years. If you look down at the bottom line, there are low and middle income countries, total just for diabetes, cardiovascular disease, chronic respiratory disease, cancer, and mental illness, somewhere in the range of $21.3 trillion. These are the kinds of numbers that under standard management models will break health systems in low and middle income countries. They will not survive these kinds of costs. So the process by which we go about conducting research and thinking about intervention strategies that can focus on these issues is really critical. It's not just obviously a test and treat model that we use a lot here in the U.S. Now, if you look at the major risk factors, there's 4 biggies that really hit home that explain a lot of this chronic disease activity and incidence. Tobacco use, unhealthy diets, physical inactivity, and harmful use of alcohol. And across the board, almost all of these risk factors influence the 4 big killers in the non-communicable disease arena. These 4 factors are common across almost all the communities that are affected. All the cultures, all the places in the world, all the countries, all the communities that are affected. In terms of the increasing incidence of these chronic disorders, they're all affected by these similar kinds of risk factors. They're not the only risk factors that are important, but they are an important part of the puzzle in almost every place. And that really, I think, puts the idea of communicable back into NCDs. The fact that we are actually transmitting these kinds of risk factors around the world through a whole variety of different processes, not only transitions themselves, the fact that economies are growing and people have more disposable income, and then the whole globalization process, whether it's trade or migration or a whole variety of other issues related to globalization that promote markets to produce and sell products that are necessarily harmful to human health. If we combine strategies, so many of the frustrations that many of us have felt in dealing with chronic disease over the years have been related to the fact that our classic models of health promotion have not been particularly effective, and that even in environments where we're seeing declines in cardiovascular disease mortality, like the United States since the 1960s, we continue to see massive declines. It's very tough to attribute that to any specific health promotion type activity. But in many places around the world, those types of health promotion activities are conducted in a setting where policies are not established to set the ground so that they might have the opportunity to work. So it really is, I think, a new approach here where we've got to make sure that institutions and policies are in place to support, that is, to plow the ground so that our classic health promotion activities and hopefully new health promotion activities can be more effective and in terms of the primary prevention of these health risks. Now, this slide came from a talk that a friend of mine, Dr. Carlos Santos-Burgoa from PAHO, who's the unit chief at PAHO for NCDs and mental health, just gave on Thursday in my department at GW. One of the benefits of living close by here is you get people like Carlos to come and talk to you. And he talked about some of the health protections and the sustainability of universal health coverage issues that are occurring within the WHO and PAHO regional plan of actions. And he talked specifically about the fact that there is no possibility for sustainable health system progress if the system and the political process does not protect against these non-communicable diseases and other health risks. And that includes those common risks that we talked about, as well as globalization risks as well. And that the 4 kind of pillars of action that PAHO and WHO have taken include health promotion, surveillance and monitoring, disease prevention, and risk mitigation. All of those have a variety of potential interventions that need to be tested both in combination, in various combinations, to decide what works best. So there's a whole variety of unanswered questions on the health services research agenda. I think it's one that has been relatively ignored in the global health arena, and one that we clearly needs to play a more important role, and that's where universities can play the most important role because we have a multidisciplinary perspective. Institutional capacities for health protection at the country level, strengthening both risk analysis and the international health regulations, surveillance and monitoring, and then thinking about methodologic approaches to complicated, multifaceted interventions that occur at the policy and community and individual level, all in combination that can help us move forward. And that includes codes of practice for business, trade agreements, and nesting health implications into trade agreements, and especially into the health treaties that we talk about. So the challenge is rigorous methodologies that combine a policy perspective and a classic quantitative evidence-based perspective, like those of us in epidemiology are more accustomed to, and need to really mix these two to come up with a methodological approach that will support those decisions. So just quick summary, we've got a huge unfinished agenda based on the MDGs, the growing importance of non-communicable diseases or chronic diseases that are associated with market forces, globalization, and the transitions that are occurring in the world call for an increased investment in research that is applied in a multifaceted, multidisciplinary fashion. Thank you very much.
Before we start the next debate, folks, Dina Fafmel has asked me a very interesting question. We're going to get as many of the presentations as we have throughout this entire conference, and we will put them on our website at CUGH.org. So please, if there are any presentations that you want or you're making, send them to us. If you want to see them, please take a look at that. And one of the things we try to do, of course, is to try to spread the word for those who are not going to be here. So you all remember it was the Academy Awards, the great selfie that was taking place with Ellen DeGeneres? Well, this is not a selfie, but this is your self-portrait of sorts. So we're going to do two. I'm going to share this around the world, and everybody who's on Twitter, right, is going to take this picture, and again, hashtag CUGH 2014, and let's share it with everybody around the world to let them know what's happening here in Washington, shall we? So, wow, this is going to be, oh, that's okay. Okay, now you got to wave, okay? Big wave. Thank you.